My name's Steve Aulman. I'm Deputy Associate Director for Business Intelligence. And I think picking up on Louise's point, it's really pertinent because I guess to a degree you've heard from the clever people earlier today around the numbers, the stats, the algorithms. What I'm here to do today is talk about how it's being used in practice in certain organisations. And one of my customers is North East Hampshire and Farnham CCG, which is a Vanguard. And I think, sort of picking up on Louise's point, I think Vanguard can, in some instances, pump prime some of these sort of transformation. But how do you then do it if you're not a Vanguard site, which I guess is the pertinent question for later. So for today's presentation, what I will attempt to cover is how the CCG are developing their Vanguard and how the risk stratification tool assists and aids that organisation going through some of their understanding around what it is they're trying to achieve. The Vanguard is a PACS Vanguard. It's a primary and acute care system Vanguard. It's looking to develop a common view, a common pooled budget for healthcare provision for local patients. This presentation is actually a presentation I've used at the steering group only recently, so it's a real and live presentation, and I've just tweaked it for the purposes of today, really just to tease out the relevance around the use of the ACG tool data. In terms of the coverage, I will be talking around what support we're providing, some of the governance arrangements, because I think it's useful for us to get our sort of heads around how that dovetails in and can be integral to the organisation, some of the key deliverables, and a bit of consideration and reflection for the audience today. Commissioning analytics, the aim here is data's great, information's okay. Intelligence is really important because then you start getting inference, then you start actually drawing real commissioning decisions off the back of this. It enables you to be able to start targeting activity with a degree of accuracy around what you're intending that outcome to be, noting that there's always a margin of error. There are 4 key components with which we're supporting the Vanguard, but 2 of them are sort of less relevant, so I've carved it out of this presentation. But the 2 that I will focus on, touching on Chris's work earlier around population segmentation and then dovetailing into the finance and activity model that's being produced in support of the overarching aim. In terms of governance, confusing diagram, I appreciate. I think the bit that I really want to draw upon is you have a number of different work streams in this system transformation, but the support work that BI and commissioning analytics does, it's not one silo. It cuts across all of the different work streams, because the danger is if you give me a number, you'll get it. You could potentially have a starburst effect where each work stream has a different question, a different number, and working on a different premise. So the intention has always been to try and have a consistent strategy in terms of what they're trying to achieve and a consistent set of numbers with which everyone can work upon, because then it gives clarity and alignment across all the different work streams on what it is they're trying to achieve. In terms of key deliverables, we touched on, and Chris has done a superb job at talking around the population segmentation work. I'm not necessarily going to labour the point here. I think for me, some of the key considerations are the use of things like long-term conditions, the use of categorisation such as age banding. These are not analytical exclusive terminology. This stuff resonates both with commissioners and clinicians. It is an easily understandable landscape with which there can be a common discussion around what it is they're trying to focus on, what it is they hope to achieve, and what the intended benefits of that targeted activity are. So we found, chatting with the stakeholder organisations, that actually this was a readily digestible and easily accessible categorisation, that when you get to charts like this and you're talking about these perfect analyst pyramids where you're seeing the resource utilisation against the number of long-term conditions and age banding, it's intuitive, we all know this, but then you start looking at some of the disproportionate usage of resources against the age profile. That starts leading some of the sort of lines of inquiry and questioning that you would want to pursue. So there are sort of 2 schools of thought. The first is, we know that the greater number of long-term conditions and the older the individual is, the greater the resource usage. there is a kind of argument to say, at this point, if they've got 5 long-term conditions and Mrs. Miggins is 80, are you really going to make a fundamental difference in how they're going to use their resources in the future? And is the question better posed around upstream activity as an earlier intervention to stop some of that resource utilisation in the future? And that's where this work's beginning to start posing some of those questions with clinical groups, so that they know their patients, so they are able to say, these types of activities are going to have, or we think are going to have, the biggest impact. Let's try an intervention and then let's see if that actually is the case. What we've also got as a piece of work is around the Overarching Vanguard, which is pump-primed from NHS England. They're putting money into it. They want a net return. They see the net return as either a reduction in the overarching costs for the system and therefore managing some of the deficit, and they want to see a blueprint that they can utilise in other geographic areas, so that they can begin to start doing some of that system transformation with the learning from the Vanguard schemes. The finance and activity model enables NHS England and the Overarching Vanguard programme to say, we anticipate through all of these different initiatives, X activity will happen, a reduction in A&E attendances, non-elective activity, a reduction in some of the primary care costs, and then we can look at the costing and the management of the resources against the deficit position with which they predict over a 5-year period. So the population segmentation work enables you to describe the what and the how, and the finance and activity model describes how much and what the net benefit for the system will be. So I've now got a really confusing diagram I'm going to share with you, and it will sort of it will unfold bit by bit, but the starting point for a lot of the conversation for us is the population segmentation began to enable us to do the as-is baselining. What do we know about the world? How many Mrs. Miggins in the world do we know who have got 3 long-term conditions and she's 50? And then we can begin to start working through in terms of either benchmark activity or through scenario modelling with the different work streams, some of those intended benefits or interventions and the activity and finance costs associated with that. And what that then enables us to do as a Vanguard is to begin to say, do you know what, X activity, X intervention is the one that we feel is most beneficial, we'll prioritise that, and they can begin to do some of the targeted activity on those cohorts to begin to see if that makes a difference. We are then looking at and picking up on John's point around the operating model, the commissioning, contractual arrangements, the budget position. You can begin to start saying, how from a contracting perspective are we going to make a difference? How is this going to materially make any other difference in terms of the way in which healthcare is either costing or is provided? And then you start defining some of your contractual framework. So that could be an accountable care organisation, it could be a lead provider model, it could be a joint commissioning approach. And then we can then start tracking through with the support from the CSU in terms of the contractual and commissioning arrangements, through to saying, did that targeted activity for the 3 long-term conditions and a 50-year-old, did that materially make a difference? And we can begin to look at, we have a series of metrics. They use something called logic models, which is an NHS England approach for the analysis and evaluation of different vanguards and different interventions. But you can begin to use that to track through to say, if this didn't work, why? If it did work, can we repeat? There are a couple of other sort of significant aspects to this. The first is, and it's picking up on sort of the themes from the Symphony project, which is, this doesn't happen in isolation. We're beginning to talk total system view of the world. So we're going to need to integrate social care, we're going to need mental health community, we're going to need the acute data sets and the GP data sets, because you are going to need every interaction that patient has with all healthcare provision. And then the overarching aim is that this particular Vanguard is really pushing hard with NHS England to say you currently have a set of regimes around the different performance metrics and system metrics. It's a recent King's Fund paper that looked at how you would potentially do performance management within a commissioning area, and it effectively said break down the barriers between the different organisations. Don't have a TDA monitor, a outcome indicator set between social care and healthcare. Actually, you want a system set of metrics, and you want to be working as a system to deliver those endpoints and those outcomes. So the last slide, you'll be glad to know, and might be able to recover some of the time, is so what for you? What does that mean? So I guess for some of the considerations in terms of the risk stratification approach is some of the learning we have is we are clearly alive to the fact that this data is sensitive. It's predominantly based on primary care data, which means it's GP owned, which means that you need to ensure that you have the appropriate information governance and data sharing agreements in place. So if you start running too quickly to the end, you'll find that at some point you'll hit the information governance barrier that says, have you got the appropriate consent by the appropriate organisation for the way in which you want to use this data? And typically the answer will be no if you don't do the thinking at the starting point. So the question I would pose is, how do you, if you're going to go down this road, how do you intend to use this information? How do you intend to, what are the audiences? How are you going to share this? Whom are you going to share this with? Particularly if you're changing some of the inter-organisational discussions. And then you can begin to start saying, if we know that we want to do a data extract and then co-join with social care data, you're going to need to identify that for the purposes of defining what your data sharing agreements will say, because it's difficult once you've already have a set of data sharing agreements in place to keep constantly going back to your GPs and interested parties to say, oh, but can you sign another form, please? And at some point, organisationally, there'll be a tension there. And the last is, once you have done that thinking, once you've got the information governance in place, you need to, what's the sort of end product for you? You've seen a number of different analytical outputs from the team today, but how often do you want that data refreshed? Someone with 3 long-term conditions isn't overnight going to suddenly eradicate them. So is this something that you'd want on an annual basis, on a 6 monthly basis, and or are there any other associated outputs that you may want refreshed on a more regular basis? So that was the end of my presentation for today, but has anyone got any questions either in relation to the Vanguard or my considerations?
I'll try and keep it a really simple question. You talked about targeted activity to make a difference. What is the expected timescale for that targeted activity identified by this to actually have an impact in terms of outcome, actually in terms of cost?
Okay.
When's it? Is it 2 years?
So the finance and activity model has a 5-year forecast. So there's a sort of do nothing scenario where you end up just watching Rome burn. It depends on the types of activities. So at the moment that hasn't been defined. Rather than a top-down approach, there are clinical groups, there are effectively GP groups coming together at each locality saying, we can do a model of care that looks like this. So there's a particular locality where they've been proactive, they are looking at a 2-year return, around 25% return on investment, but that needs to be pumped in year 1 in terms of getting the infrastructure in place and amending some of the ways with which those GP practices are working together with the community provider and the acute care provider to provide some of those 25% returns year 2 and 3 and 4 onwards. So at the moment, this is not necessarily, it's done as an organic development, bottom up, rather than necessarily someone clever at the top saying it must look and feel like this. Does that help or hinder?
I think it was the word front priming which sort of fell calling bells in my mind.
Yeah, and I'll be honest, Vanguards have been a vehicle with which NHS England are using this to make some of that bigger system change, and they are very ambitious in their aspirations for the Vanguard schemes, and they want them to be big and they want them to be fast.